Welcome everybody to this afternoon's webinar. As you know, this afternoon Tuberous Sclerosis Australia is hosting this webinar, and the very generous Dr. Chirag Patel is joining us as our presenter. For those that don't know me, I'm Claire Stewart. I'm the General Manager of Tuberous Sclerosis Australia, and just wanted to do a really brief introduction before I hand over to our main speaker. So I wanted to let you know that today's conference was supported by a grant from Novartis, but they've had absolutely no input into the topic selection, how we advertised it, and certainly not the content. So it really is just a matter of obtaining some funding so we can make educational events like this happen. For those that aren't familiar with Tuberous Sclerosis Australia, we've been around for a long time. Really, was formed as a patient support group, and although our activities have grown and become more broad, we remain really focused on the needs of people living with tuberous sclerosis. Our activities are really focused around information and support activities, advocacy and research. So you can see there that our phone number and our email address, if you have any questions, either coming out of what you learned today or at other points in your life with tuberous sclerosis, please pick up the phone, please send us a note, and we'll do our best to either be able to answer, listen, or find out the answers to your questions as you go through. I encourage you to look at the other options out there, including our Facebook group, a great place to talk about tuberous sclerosis, our online website information pages, our magazines, which are always focused on a different issue each time. And also, the upcoming issue in October is focused around the kidneys. So really keen to share, updated information at various points. So I will now say goodbye. I'll come back at the end to do a bit of a close down, but I'll hand over now to Dr. Chirag Patel, who's been a fantastic supporter of TSA over the last few years, after he has luckily taken an interest in tuberous sclerosis in his practice up at the Royal Brisbane and Women's Hospital in Queensland. So I will go now. You can remove my lovely face from the webinar, and I'll talk to you in a little bit. Thanks, Chirag.
Brilliant. Thank you, everyone, for joining us on a lovely weekend. It's quite sunny up here in Queensland. I'm not sure what it's like in different states. I'd like to thank TS Australia for asking me to do this talk, which I did at the Patient Day last year, just with a few updates and some additional comments. So hopefully today I'm going to cover the genetics of tuberous sclerosis and cover some of the aspects of lifelong surveillance. I apologise for my first slide. The webinar was originally due in July and I forgot to edit the date, so obviously it's for today's date. So just an overview of what we're going to talk about, really starting off just a bit about what genetic service is and part of what my department and my colleagues will be involved in patients with tuberous sclerosis, and then we'll talk a little bit about the diagnosis and lifelong surveillance, so the key points that we want to get across, and then I'll discuss in more detail about the genetic aspects to tuberous sclerosis, what this means for family members, questions always raised about genetic testing and family planning, and these are the kind of things that we would cover in a genetics appointment, so hopefully by the end of the session everyone will have a good understanding of everything. My first poll for the audience is finding out how tuberous sclerosis affects you. So either you're an affected adult, or you have a child with this condition, or a relative with this condition, or you're just an interested person. So let's see what the poll shows. Okay, so out of the people that are here, 50% I guess have a child with it, and then hopefully everyone can see what the poll results are. They have a relative or they're actually affected with this condition themselves. Okay, moving on to the second poll. So for those people who are here, have you ever seen, or are you due to see, a genetics team at all? So if we can do our second poll, yeah. Okay, so the majority of people have seen a genetics team. Okay, moving on to the third one. So obviously those who have seen a genetics team, hopefully you'll say yes to this, but do you know what the role of a clinical genetics team is? Okay, that's interesting that the one person who had been was still a little bit unsure. So, okay, hopefully we can clarify that a little bit better. So let's just talk a little bit about genetic services. So, these are present in every state in Australia and are available in the public health system at no cost to patients. There are private services, but my remit is in the public system, and that's where it's more widely available, so I'm only going to really talk about public services. Usually the genetic service departments are located in one major hospital, but will provide outreach clinics. So for myself, our department is based in Brisbane, but we cover the whole of Queensland, so we will do regional clinics to Cairns, Townsville, Mackay, Bundaberg. We do a lot of telehealth facilities, and other states will have similar sorts of setups as well. Patients or family members are referred by their GP or medical professionals, and the services consists of medical staff as clinical geneticists like myself, and there are genetic counsellors who have a background in either nursing or have done a master's in genetic counselling. And essentially what we do is provide genetic counselling. Now, as the two words go, it's a little bit difficult to understand what genetic counselling is. So let's go through a bit of a definition of genetic counselling. So this is really an educational process that seeks to assist the person who has the condition or is at risk of a genetic condition to understand, well, what is the nature of the genetic disorder? What are the management, surveillance issues as part of that condition? Help them to understand what the genetic basis to the condition is, the inheritance within the family, and what that may mean for their relatives, either their children, their siblings, their parents. Part of the process also discusses the role and availability of genetic testing, and then another aspect would be options for family planning for those who are looking to go down those avenues. So you can see that, a consultation for, a diagnosis of tuberous sclerosis, when we see people, covers all these aspects. So this isn't something that we want to do in 5 minutes. And so our consultations will generally run for 45 minutes to 60 minutes because there are a lot of things to cover. So hopefully the process of this webinar will cover a lot of things that we would normally go through in a clinic, but obviously it will be tailored to the individual person and their sort of situation as well. So let's go through each aspect and how this relates particularly to tuberous sclerosis. So with the nature of the condition, now I'm not going to go into too much detail about the sort of diagnostic criteria, but these are have been internationally agreed and are very readily available to all medical professionals, particularly who are the first-line doctors seeing people with suspected diagnosis tuberous sclerosis. And these are available on the Tuberous Sclerosis Australia website as well. But essentially it's important to appreciate that this is a multi-system disorder and that the features can continue to develop over a lifetime of an individual. And I think this is something that we're starting to identify in patients who are seen as children and followed up very well, and then may seem to sort of fall through the gaps as they transition into adult services where there may not be coordinated clinics available, keeping an eye out for some of these other organ systems where issues may develop as adults. And so, in the past, maybe people were falsely reassured that, oh, you haven't developed this feature yet, you're not going to develop it ever, and then they develop it as an adult. So I think this is what medical professionals are starting to appreciate a little bit more, that this is a sort of a lifetime condition and therefore surveillance is really important. Now, with regards to the diagnosis, I guess this can be made via a genetic diagnosis, and we'll go into that a little bit later, or traditionally it was always made as a clinical diagnosis. And so that involved well-defined clinical diagnostic criteria. So when people present to clinics, either genetics clinics or neurology clinics or skin clinics, if a diagnosis is suspected, then I would like to hope that the clinicians will be going through these diagnostic criteria to review how many that particular person has. If there is a suspicion of a diagnosis of tuberous sclerosis, then they should be really looking for some of these other features via other opinions. So, you know, head imaging for some of the brain abnormalities, the kidney issues, the lung issues, some of the skin manifestations. So, you know, going through this diagram, I guess we've got on the top left-hand side, we're talking about the nodules that are present within the brain. The middle picture on the left-hand side, I'll just get my laser pointer up, sorry about that. Here we go. So the middle picture on the left-hand side is highlighting the kidney angiomyolipomas. The bottom left is a picture of a lung trying to highlight the lymphangiomyomatosis, so LAMS. They're quite complex words, so it's good we've got abbreviations. On the right side, we've got all the skin manifestations. So you've got the facial angiofibromas, the nail changes, the chagrin patch, third one down, and then the light-coloured or hypomelanotic skin pigmented lesions. So it's really looking for some of those, and then obviously depending on how many you have, you can make either a definite clinical diagnosis or a suspected clinical diagnosis. And that is what we used to use traditionally before genetic testing came along. So moving on to the next part of genetic counselling really is the management and surveillance of the disorder. So our next poll for the 5 individuals now we've got here, do you know what the surveillance for tuberous sclerosis is? Okay, that's very reassuring that the majority of people do know. I'm not going to test you and ask you individually. But again, we have very well-defined, internationally agreed guidelines on the surveillance and management of each of the different organ systems for tuberous sclerosis patients. And again, these guidelines are available on the support group website, and they are readily available to healthcare practitioners. So, you know, I always say to patients and families that you should have that sense of, you know, ownership about the condition, and do feel confident in presenting these kind of guidelines to your healthcare professionals, because you can't always presume that they may know or have that experience in tuberous sclerosis, especially, you know, if you are in regional centres and are not seen by dedicated multidisciplinary clinics. Okay, I can see a few comments happening on the left-hand side, which sort of I agree with. I think someone's mentioned about having to convince their doctors what to do with the guidelines. I think this is a common scenario in particularly regional centres, and I think it just relies on, again, patients being very, you know, not necessarily forceful but proactive, but also then trying to find the relevant individuals who do have an interest in this condition. If that does mean going to a tertiary centre for that sort of ongoing surveillance, then that is something that we would recommend and try and encourage people to do. It is very difficult. Each state has their own setup, and so some people do fall through the gaps or are managed slightly differently, and so I do appreciate the challenges that some people have, and I can really sort of empathise with that, because, you know, seeing other genetic disorders which are multi-system like tuberous sclerosis, we have a very similar issue about coordinated care, even when there are very clear guidelines and people are either having too many scans, too infrequent scans, etc., etc. So anyway, just going through what we do know. So these are again quite nicely highlighted on the patient website. So I'm just, you know, pulling them out individually. So when we go through the genetic recommendations, again, there's always the offer of genetic testing and seeing a genetic service, but that's not necessarily mandated. From a neurology perspective, it's performing EEGs in either people who are known or suspected to have seizures, monitoring for some of the neuropsychiatric features at various stages throughout, particularly childhood. And then with the MRI scans, the frequency, again, is dependent on the neurologist and the person and their symptoms, but recommended up until the age of sort of 25 years. Now, all of this will be tailored depending on the individual person. So these are sort of obviously broad guidelines, and guidelines are guidelines, but they're good for people who aren't having anything. But for those who are having something, there can be some debate between individual physicians and patients. From the kidney perspective, again, there are abdominal MRI scans every 1 to 3 years to monitor particularly for the kidney AMLs and also the cysts, your blood pressure and your kidney function tests. Those are really important because those are factors that we can measure readily, your GP can do. The skin lesions obviously being monitored either by yourself or by a dermatologist with various avenues for treatment if they become significant issues. The dental issues, I guess, are not so readily, I guess, picked up or monitored, but, obviously we should all be seeing a dentist twice a year, but particularly with tuberous sclerosis, going in with that particular question of keeping an eye out for some of the enamel issues and the pits and things like that. With the eyes, we usually find that, as adults, you can generally report if there are any concerns about your vision, so you're more likely to go to an ophthalmologist. I guess as young children, a little bit difficult, so sometimes a review every year is quite beneficial, particularly at ages when they're not able to report any visual issues. With regards to the heart, an echocardiogram for those who've definitely previously had rhabdomyomas, and then an ECG every 3 to 5 years to look at rhythm disturbances. And again, this is at any age. The lungs, I find, are probably ones that are slightly forgotten about in the adult population, but this is obviously very important, particularly in females, to particularly be screening for symptoms of shortness of breath, etc., and then doing a more sort of detailed scanning with high-resolution CT scans in people either who don't have symptoms or more frequently if they do have symptoms, along with lung function testing, because it's great if you find something, but you want to know what the impact that is, what impact that's having on someone's respiratory function as well. All right, so let's move on to, reviewing that. So as a person who's affected or has a child, how easy has it been to access specialists? Okay, so everybody has said it's been very hard. So hopefully I'm resonating some of the issues that we see as medical specialists when we're seeing people or parents of children with tuberous sclerosis about accessing relevant specialists. I think in the pediatric setting there are more drives towards coordinating multidisciplinary team clinics where the child attends the one clinic and sees every specialist in over the space of the whole day, hopefully. I definitely know there's a paediatric clinic here in Brisbane and there's one in Sydney. As for the other centres, that may be because there just aren't those individuals available who have a special interest or have seen enough patients with it, and I guess they may not have the confidence to be part of that clinic, and so I guess these individuals are being seen by individual specialists, and I think that the thing that people find most tricky is someone who's coordinating all that care, is on top of all the different issues, which in children could be coordinated by a general paediatrician, but I think as you transition into adult services, I think GPs are finding it quite difficult, and there doesn't seem to be a medical specialist who takes full control over that, but it just relies on each state having their own person interested, but hopefully as there's increased awareness, increased drive from patient support groups, that may happen with time. So as Claire's highlighted, one of the other benefits of the patient support groups is contacting other families and finding out, well, which specialists have they seen, where have they seen them, were they any good, were they helpful in addressing the queries that you have, and that's what I usually advise patients, depending on where they're living, is if they're really struggling, is that's a avenue to get that further information, because unless especially if we don't have a particular person to send them to, particularly sort of relating to neurology or dermatology. I think the kidneys, there's quite a few people quite interested in tuberous sclerosis, so have experience with that. All right, okay, so let's move on to the genetic aspects of the condition. The genetic basis, we've got our next poll. Tuberous sclerosis is caused by an environmental factor, a chromosome abnormality, a gene mutation, or I do not know. Excellent. Everybody got that answer correct. So it is a gene mutation. So what I want to do is just sort of go through some basic genetics. So genetics can appear quite complex, but essentially this is how I explain it to patients when they come to clinic. So the way to think about genetics is our body is made up of millions of cells, and that's what I'm highlighting with the red pointer. So we've got skin cells, blood cells, kidney cells, brain cells. And within the cells are these structures which we call chromosomes. That's this big thing on the left-hand side. Now, essentially what a chromosome is it's the packaging material for all of our genetic information and the blueprints that tell our body what to do. Now, in each cell in your body, you should have 23 pairs of chromosomes, so we all have 46, because we inherit 23 from our mother and we inherit 23 from our father. If we were to stretch that chromosome out like a long piece of string, what it's made up of is what we call DNA. And on the chromosomes are our genes, which I describe as individual instruction manuals, like you get for your TV and your dishwasher. So a cell has 46 chromosomes, which I say are a bit like bookshelves, and then on the bookshelves are the individual genes, the instruction manuals. So, and this just highlights that sort of resolution that I was talking about in the analogy. So you've got the chromosome on the top, which is a bit like a bookshelf. As you zoom into that bookshelf, we've got 10% of it there, which has got around 40 genes, so 40 books. If you zoom in again, so on 1% of that whole bookshelf, you've got 4 genes here. So there are sections in between that really are what we call junk, a bit like empty parts of the bookshelf, but then you've got those clear-cut books there. So when we're thinking about tuberous sclerosis, out of those 24,000 genes, we know that there are 2 well-documented genes associated with tuberous sclerosis, which we call TSC1 and TSC2. We weren't very inventive when we named them. And TSC1 is located on chromosome number 9, so bookshelf number 9, and tuberous sclerosis 2 is located on bookshelf number 16. Again, we all have 2 copies of both of these genes, and these genes actually play a role in normal cell processes. So this diagram is a little bit complex on the bottom left, but what it's showing is that a pathway within our cells where TSC1 and TSC2 interact to essentially they put the brakes. That's what this sort of arrow with
No. Okay. The first one went without a hitch. Just going to see if I can contact him. Louise, you can hear me, but I'm pretty sure we still don't have Chirag. He's presenting away, I think, which feels unfortunate. Oh. Chirag, are you there?
Hello?
Oh, you're back!
Hello? Yes, sorry. I didn't even realise I was off. I just carried on presenting.
So I think we need to go back a few slides. Let me just take us back. So,
where we
so I'm fairly sure we were just talking about the TSC1 and 2 proteins and their role in the body. So I need...
Okay, fine.
Yeah.
I'll go back.
Sorry about that. You were doing a great job,
Okay.
but you also froze and went silent. I'll go back on mute.
Carried on going. Okay, just yeah.
You can remove my beautiful camera. Thanks, Redback.
All right. Okay, sorry, I apologise for that. I thought I was still okay, so I just carried on presenting. So I'll go through this slide again. Essentially what I was saying about the genetic basis to the condition is that out of the 24,000 genes in our bodies, we know that 2 genes, TSC1 and TSC2, are associated with tuberous sclerosis. Now, we all have both of these genes. We have 2 copies of both of these genes, and these genes, the protein products, play a really important role in various cell processes. So what this diagram is showing you here is the TSC1 and TSC2 proteins here in red. And essentially what they do is they block, and that's what this arrow with the bar is, the mTOR protein. Now what mTOR does is it drives a number of these processes down at the bottom. So it drives cell growth and proliferation. Angiogenesis means sort of blood vessel development, cell metabolism, cell migration orientation. So you can now see that if an individual has an abnormality in either TSC1 or TSC2, that essentially removes the brake system to this pathway and therefore results in that overgrowth or proliferation and some of the features that develop in tuberous sclerosis. And the beauty of identifying the underlying genetic basis in genetic conditions is then you can look at the pathway and tailor particular drugs. So we now know obviously mTOR inhibitors, the reason and the way they work is they block mTOR here, which is what essentially TSC1 or TSC2 would be doing, but obviously aren't doing in patients with tuberous sclerosis. So that's what I wanted to highlight on this slide. What I said already, that obviously we all have these genes, but it's an error or what we call a mutation in one of these 2 genes that causes tuberous sclerosis. However, a mutation is only found in about 85% of patients, and we'll address that a bit later when we talk about genetic testing. And essentially the mutation stops the gene from working, it stops there being a functional protein, and therefore you don't get that blocking of mTOR. We know that when you compare people with TSC1 and TSC2 mutations, generally people with TSC2 mutations have more severe clinical manifestations or clinical disease. Okay, so let's move on now to, well, when someone does get the diagnosis of tuberous sclerosis, what does that mean for family members? What's the inheritance of this condition? Okay, so to our next poll. So if someone is affected by tuberous sclerosis, the chance that their child will inherit the condition is, and please select one of those options. I'm hoping, because most people have seen a genetics team, they're going to get the right answer here. Hooray, everyone's got the correct answer. Brilliant, okay. All right, moving on to the next one. So just showing you in diagram form. So what we have here is on the right hand side you've got a parent who does not have tuberous sclerosis. They have 2 normal copies of this gene, which I've represented in white bars. This could be TSC1 or TSC2, so let's just hypothetically take TSC1. On the left hand side you've got a parent who has 1 mutated gene, the red bar, and 1 normal gene. When we have children, we pass on 1 copy of all of our genes, so it's a bit like divvying them out. So the parent who doesn't have tuberous sclerosis has only got normal copies of this gene to pass on, whereas the person who has tuberous sclerosis is either going to pass on the abnormal gene or the normal gene. So if you follow all these combinations through, on the bottom right, you've got a child who's inherited 2 normal copies of the gene, 1 from each parent, so they'll be unaffected. The next one, exactly the same scenario, unaffected. So these 2 individuals cannot pass this condition on because they've not inherited it. They've only got normal copies of this gene. They cannot pass this on. Whereas on this side, you've got an individual who's inherited the abnormal copy from the one parent and the normal copy from the other parent, so they will be affected with tuberous sclerosis. And then same with this person here. So again, these individuals are affected and they can potentially then pass this on. So when you look at this diagram as a whole, we would say that there's a 2 in 4 or a 1 in 2, 50-50 chance of passing this condition on. And this is, in genetic terms, what we call autosomal dominant inheritance. So there are many genetic conditions inherited in this manner. When we look at families of tuberous sclerosis, especially multiple generations, if you draw out a family tree and start shading in people who got the condition, this may be an example family history. So what you tend to see is there are multiple generations affected. We don't tend to see skipping of generations, so you wouldn't see someone who has no clinical features passing the condition on, so having a parent and then a child with this condition. We tend to say that anyone who has an abnormality in one of these genes will present with features. Males and females are affected, the condition can be passed on by males and females, and therefore each child has a 50-50 chance of inheriting the condition. So the next poll, people who are affected with tuberous sclerosis in a family will all show the same clinical features. Excellent. So everyone really paid attention to their genetic consults. That's really good. So that's correct. No, they do not all present with the same features. So, and this is due to a few phenomena. So the one thing we always say with tuberous sclerosis is that it is 100% penetrant. Now, what that means is the proportion of individuals who have a gene mutation who are clinically affected. And that's what I was highlighting in that family history diagram, is that anyone who has an abnormal gene will definitely present with symptoms. So there's no skipping of generations. It's this next bit, the expression, or what we call variable expression, which is the degree to which a person presents with clinical features. Now, although within a family you'll all have the same abnormality in the same gene, how it affects you will vary between a family and within a family, and that's due to factors that we do not yet know. They could be other genetic factors, and I think that's really important to appreciate, that there will be some people who are more severely affected and some people more mildly affected even within a family, and there's no way of predicting which way someone is going to go based on their family history. And we definitely wouldn't say that it gets worse as the condition gets passed down generations. That's not a phenomenon we see in this condition as opposed to other genetic conditions that can be inherited in this way. So when we see people with tuberous sclerosis, generally there will be a positive family history in about 1/3 of individuals. For that, there'll be an affected parent, and therefore there would have been that 50-50 chance of inheriting the condition. And however, in 2/3 of people we see they are the first person in that family to be diagnosed with tuberous sclerosis or have the condition. Now, there's a number of reasons behind that genetically. Now, that's either because they are what we call a new mutation or a de novo mutation. Essentially, what that means is this condition has not been inherited from either parent, but that mutation has happened literally on day one as the egg and sperm have come together, and this new mutation has happened by random chance. It's not usually due to any environmental factors or there are lots of theories that people present with in clinic, but generally there's no plausible explanation. It's a random act, a random chance. The other phenomenon is what we call gonadal mosaicism. So this is where, although neither parent has got the condition, what we cannot ever exclude is either some sperm in the father or some eggs in the mother have this mutation, even though in the rest of their body they do not have a mutation, so they're clinically unaffected. And so in this scenario, or not knowing which of these two scenarios applies when we see someone where there's no family history, we would give them a recurrence risk of around 2%, or a sibling risk. So if we're seeing a young child who's got tuberous sclerosis, the parents have been assessed, there's no clinical features, or they've had a genetic test and they don't have a mutation, we would be giving them that sort of 2% recurrence risk. And this is because of these, we cannot ever exclude that there might be some abnormal sperm or abnormal eggs. Obviously, if one of the parents has the condition, then it's 50%. So that's quite a significant difference, but important to appreciate that the risk never goes down to 0. Okay, so let's talk about now the role and availability of genetic testing. So how many individuals present today have actually had a genetic test for tuberous sclerosis? Yeah, I'm back. Hello. I have no idea what's going on. I blame the hospital. I blame the hospital instead. I'm assuming I got to the have I had a genetic test slide. Okay, so I can go back to the poll. It's good that I'm paying attention to the chat, otherwise I would just keep going. Okay, it seems like I just have to refresh every 10 minutes or something. That might be a good idea. Okay, are you still there? Okay, right, let's go back. Okay, sorry everyone. I think I'm doing the presentation from the hospital, so I blame the hospital internet. This is what I've got to work with. Okay, so I think we got to the poll of have we had a genetic test, and it sounds like the majority of people have. So the next poll is for those of you who did. So I've got 4 out of 6 people. What was the reason for actually doing the genetic test? Was it to actually make the diagnosis? To clarify your own risk of having tuberous sclerosis, or was it because you're pursuing reproductive avenues, or you're not really sure why the test was done?
Yeah, so it sort of froze while we were doing the poll, but I think we've all entered our poll response right now.
Okay, so that's an interesting one. We've got a couple of individuals who are pursuing reproductive avenues, and then people who are trying to clarify their risk and make a diagnosis. So this is quite, leads on to, I guess, the issue of, I guess, why would we do a genetic test? And I think that's highlighted nicely by the poll results. So when we think about genetic testing for any condition, and if I target it specifically to tuberous sclerosis, there are a couple of different types. So the first thing to think about is what's the role of the test. So is it a diagnostic test? Now essentially that involves a blood test, and what you're trying to do is find a mutation in one of those 2 genes, and essentially what the test is doing is screening the whole of those 2 genes to find an error in that gene, in one of those 2 genes. So it's there for diagnostic purposes to either confirm a suspicion of tuberous sclerosis, or if there's an individual who has maybe 1 or 2 features, doesn't quite fulfill the diagnostic criteria, and therefore the genetic test may help bump them into that definite category. That would be an avenue for a reason for doing the test. Now, the test is not required if you have a very clear, confirmed clinical diagnosis. So for someone who has the diagnosis, you have to think, well, why are we doing it? Not if it's a very clear, confirmed diagnosis. So the next role of doing genetic testing would be for reproductive avenues. So these are for families where there is a confirmed diagnosis and individuals are wanting to go down avenues, which we'll talk about a little bit later, to clarify their risk of having either another child or having a child with the condition or passing it on. Now, in order to pursue reproductive avenues, you need to know what the mutation is that runs in the family, so either in TSC1 or TSC2, and that will then open up reproductive options, which we'll discuss a little bit later on. The other role of genetic testing is what we call predictive genetic testing. So again, it's a blood test, but this is for the category of people who we would put at, say, are at risk of this condition. So these are either siblings or children of people with tuberous sclerosis, and either they are adults or children themselves. Again, this does require identification of the family mutation because you need to know what you're testing for. So you always, when we see families with tuberous sclerosis or someone has a family history of tuberous sclerosis, we need to know what the result is in the person who has the condition before we can offer a test to someone who, at the current stage of assessing them, has no clear clinical features or wants to know, are they going to develop any features? Now, the nature of this test is slightly different, so it requires quite complex genetic counselling to discuss the pros and cons of having a genetic test. So for an individual who has no symptoms, what would be the advantages? Well, the advantages can be to help maybe if they've got maybe one suspected feature or someone suspecting a diagnosis, if that individual needs to be plugged into the relevant management planning, so the screening of all the organ system issues that we talked about earlier. For young children, where there is a sibling with tuberous sclerosis, there can be some parental anxiety whether their other child is going to develop this condition, so that's the potential advantage to knowing. And obviously we talked about reproductive planning, so if we have a young individual who has a family history, they want to clarify their risk before they start a family of their own. The disadvantages of doing this form of testing is it can bring out some psychosocial issues, particularly regarding sort of genetic guilt. We see a lot of families who then sort of either assign blame or feel guilty about passing this condition on. There can be diagnostic stigma being labelled with a condition, and how that then impacts you, particularly with regards to employment, finances, getting life insurance, mortgages, things like that. If you currently don't have any symptoms, you may develop anxiety regarding some of the symptoms or some of the issues that may arise. If you've got two children, one who has the condition and one who hasn't inherited the condition, do you change the way you raise those children? And then when we're thinking about genetic testing in young children, there's always the issue of loss of autonomy. So that child personally has not made that decision, although the parents are doing it in their best interest. What we don't know is how will that child feel when they're an adult? Would they have ever wanted to know? And the reason why I raise these issues is, we see families over a lifespan. We see kids who then grow up as adults and come back to genetic services, and sometimes some of these individuals do say they wish they hadn't known when they were younger children, wish they could make that decision themselves. So these aren't just theoretical issues that come up. These have been well explored in many genetic conditions, so I think important to be aware about. So what about the availability of genetic testing? So look, in Australia this is very readily available. It's performed via a blood test. The results usually take around 3 to 6 months. Now, this is not because the sample's just sitting there on a bench, but as you could appreciate, these tests are quite complex. They're not automated by machines like kidney function tests are, liver function tests, or your iron levels. These require quite sophisticated technology and then human manpower to interpret those results. To say, are these significant? Are they abnormal? Are they not abnormal? In Australia, there is a laboratory in WA that offers the test, and in the public healthcare system, this is paid for by the medical team requesting the test. So if it could be your renal team, it could be your neurologist, it could be your genetics team. All right. I think it's almost one of my last polls. So a genetic test for tuberous sclerosis will always find a mutation, and hopefully if you've been paying attention, you should know the answer to this one. Excellent. Okay. So the answer is no, it won't always find a mutation. So what are the outcomes of doing a diagnostic genetic test? So this is when we've got someone who's got clear-cut tuberous sclerosis. So in 85% of patients, we will find a clear-cut abnormality, so that's what we would term a positive result. However, 15% of patients, they have no mutations found. Now, we have to appreciate that we're doing all this genetic testing on blood cells. Now, there are a number of reasons why we might have a negative result. Now, either that the test is not 100% accurate, and that's a possibility because our testing is evolving. There may be parts of that gene, which, as I said, is a bit like a book, that we're not very good at looking at. So either the appendices or particular chapters, we're not able to look at them in great depth to find anomalies. The more likely explanation that we feel accounts for about 15% of people is what we call somatic mosaicism. So this is where there is a mutation in one of these two genes, but it's actually only present in certain cells or organs. So all these genetic tests are being done on blood samples which we feel represent the rest of the body, your kidneys, your brain, etc., your skin, but there are conditions where only the mutations are found in the organ tissue that is abnormal. So for some patients, they will go on to have testing of maybe their skin lesions, the kidney lesions, usually are not removed. But if they are, then that may be a tissue to test. But it's very difficult to start testing every cell in your body. You're obviously not going to be testing brain tissue, and so sometimes for some people we aren't able to provide that concrete genetic result or confirmation, but they still have a very clear clinical diagnosis. Now, I mean, the final explanation for having a negative result is that there might be a third gene for tuberous sclerosis, but I think this final explanation is becoming less and less likely, although there's obviously a lot of research going into this, but I think we're not likely to find a third gene. It seems less likely now. So these are just some, I thought I'd put in some examples of some reports of positive results. Just to sort of highlight the fact that each person may have a different error in their gene. So this is just the top report is a person who's got very clear tuberous sclerosis, and the result says a pathogenic variant, so a significant variant has been found. There's obviously some complex language that the laboratory used, but essentially what I want to show you is you've got a tuberous TSC2 mutation, and then the terminology used, which essentially describes where in the book, which page, which word, which line that mutation is. And then the comments usually tell us about how the testing was done, what type of testing was done, etc. And then the bottom report, you've got another patient with a tuberous sclerosis TSC2 mutation. So depending on which lab does the testing, the reports will vary a little bit, but I think the take-home message is that different people will have different mutations, and you can see this person has the numbers 771, this person has 1760, so further along in the gene. Okay, now, and this is a report of a person who's got a negative result, so this is no clearly pathogenic variants described. As I said, this does not change a clinical diagnosis. If you have a clinical diagnosis, a negative genetic test does not remove that diagnosis. And so in this scenario, when we're talking about relatives and clarifying their risks, we have to base this on the family history. Anyone who wants to assess whether they are at risk will require detailed clinical assessments. So that will involve, clinical examinations of their skin, imaging of their kidneys, their lungs, their brain, to look for any features of the condition. But unfortunately, if you don't have a clear result in a family, you cannot offer a genetic test to relatives. And obviously, you cannot offer a test in a pregnancy because you don't know what you're looking for. You need to know what you're looking for before you can offer a test to relatives. All right, so the final aspect of the talk is options for family planning. So I think one thing that I'm definitely seeing in a lot of young females that we see in clinic, in the genetics clinic, who come to genetic services because they have the condition and they want to know about pregnancy planning, etc., is actually taking a step back and thinking, well, how do we go about family planning? What are the other issues? You know, we can talk about the genetic stuff quite easily. What are the risks, etc. But there are things that people don't always consider. So, you know, many people are on complex and cocktails of medication for epilepsy, for their AMLs, for their LAMs, and therefore we have to appreciate as a medical specialty and as families and patients with tuberous sclerosis, well, what are the effects of those medicines on my fertility? Would I need to be stopping any of those drugs before I start planning for a pregnancy? How will they impact my fertility? What are the effects of those medications on actually a developing baby? So particular drugs used for high blood pressure, we know can have a negative impact. Drugs used for epilepsy, we know can have a negative impact on a developing baby. So these are discussions that have to happen with the relevant specialties about whether the person is on the right drug for a pregnancy. And then also for that young female, that particular female who's thinking about bearing a pregnancy, is, well, what's the risk to that person? And that's going to be based on actually the severity of their kidney and lung disease. As you can imagine, a pregnancy, you know, changes a lot of things about your body, but it puts a lot of stress on your kidneys and your lungs just in a normal state. And I guess if you have any form of kidney disease or lung disease, having a pregnancy can also impact that as well. And again, so these individuals have to have those discussions with their kidney specialist, with their lung specialist about, well, what will a pregnancy do to my current lung status, my current kidney status? Will it negatively impact that? How will I be monitored in my pregnancy? Will I be a high-risk pregnancy, a low-risk pregnancy? And therefore, you know, most people with tuberous sclerosis embarking on a pregnancy, we wouldn't want them to be managed you know, out in the community. They want to be in a tertiary hospital so that people are aware in case any issues arise. And then also, you know, we've talked about, I guess, the two things, sort of the effect of actually the pregnancy on the disease itself, which is similar to what I've just said. Probably should have merged those two issues together. So I always advise families who are coming forward for family planning is that a lot of these issues have to be discussed and thought about almost, you know, 6 months, a year before you even think about wanting to embark on a pregnancy, because it may involve complex changes of medication, monitoring of disease, seeing specific obstetric consultants who have experience in complex disease, seeing specific obstetric consultants who have experience in complex patients with all forms of medical disease, medical conditions, to get that guidance about how a pregnancy should be managed. But once all that's done, then I guess what are the avenues that families can go down? So I think it's about being fully informed about your risks. So obviously seeing the genetics team and knowing, well, you know, is there that 50% risk? Is there that gonadal mosaicism risk? But the route that a family will take will depend on their own individual views. And I think this is something that is really important, that is not directive. You know, families should not be coerced into a particular direction. As genetics teams, we use non-directive genetic counselling, and so, you know, we're here to present all the information as to all the different options available, and then it's up to the couple and the family themselves as to which avenue they go down. So what are the avenues that people may go down? So, well, the first one is actually doing nothing. You just let nature take its natural course. You appreciate what the chances are of having a child with tuberous sclerosis, and you just sort of plan your pregnancy accordingly, get followed up by the relevant specialists. Then there's sperm or egg donation, and then there are various testing options in the pregnancy, which I'm sort of going to go through. So the do nothing, the natural cause, now that avenue can be pursued or is pursued by parents who generally have a low risk to having another child with this condition. So those are those de novo cases that I was talking about, or for families where they wouldn't actually pursue pregnancy testing options for, you know, personal, ethical, religious reasons. This may be an avenue where where there isn't a genetic cause found. Obviously, we don't have any testing options, so this may be one of the only options you have. And so for these families, they may say, well, we'll just wait till the child is born, we'll have them clinically assessed, or if there is a genetic test, tested after birth. For those who go down the sperm or egg donation route, again, this is for those who may not pursue pregnancy testing options. There may be either fertility issues already, and they may be, you know, already going down the avenue of egg donation or sperm donation. But again, it may be used for those families where we don't know what the genetic cause is, there's no mutation found, and obviously if it's coming from the father, then you may go down the sperm donation route. If it's coming from the mother, you may go down the egg donation route. So that is an avenue that some families may pursue. But the more common avenues that we tend to see in the when a diagnosis has been made and that there is a mutation within the family is the first one here is what we call invasive or prenatal genetic testing. Again, this is available in the public and private systems. In the public system, obviously, this would be at no cost to the families. So the first test is what we call a chorionic villus sample, and so that's the picture on the bottom left. And essentially what that involves is a fine needle that goes through the mother's abdomen under ultrasound guidance. And essentially what they're doing is they're taking a sample of the placenta, which represents the baby. Now this test is done from 11 weeks into the pregnancy, and given that it's early in the pregnancy, there is a miscarriage risk of around 1 to 2%. A test that's performed a little bit later on in the pregnancy is an amniocentesis, which is the picture on the left, which again is a needle through the tummy using ultrasound guidance, but this time it's the fluid around the baby, which again has got cells representing the baby, what we call the amniotic fluid. Now this test is done from 16 weeks, but there is a lower miscarriage risk. Now both of these tests, again, like I said, rely on there being a mutation known in the family, and so the test is very specific and very targeted, and it's looking for that family mutation to say yes or no, does the baby have that mutation, and is he or she at risk of developing tuberous sclerosis? The final option that some couples may go down is what we call pre-implantation genetic diagnosis. Now, again, this relies on knowing what the mutation is within the family. Unfortunately, in Australia, this is all privately, so self-funded. Now, this has to be done through specialised PGD centres, so this is not done by any IVF specialist. Because the process essentially is doing IVF, and so the couple could be fertile, they could be non-fertile couples already going down this process, but essentially embryos are created in the laboratory, and then those embryos are tested for the family mutation, and then they will only put back the unaffected embryos that don't have the mutation. Now, I've said that in essentially 1 or 2 sentences, but as you may appreciate, IVF is not a straightforward process. It's quite financially significantly can affect families. It's quite a lengthy process. The actual process itself can be quite emotionally and psychosocially impacting on couples, relating to hormones, etc. And what we have to appreciate is that, you know, going through the IVF process, you may create 10 embryos, and then out of those 10 embryos, we don't know how many of them may have the mutation, may not. You may end up with only 2, and again, when 1 or 2 of those are put back in, then there are the chances of actually that embryo going through to live birth. So there's a number of hurdles through this whole process. So, you know, I think we have to appreciate that this is a complex process. It is obviously available to individuals, but it's not something that's going to happen overnight. And so we always say to families who might think about going down this avenue is to make contact with these specialist PGD centres, have an appointment with them, find out, you know, the cost involved, the time it takes, so that you can plan your family accordingly. You know, as I've highlighted in the last couple of slides, it's not only thinking about, well, how's a pregnancy going to impact me if I have this condition, but also when do I plan my pregnancy if there are these other complex issues regarding testing involved. Now, I'm just putting this slide in because a lot of people talk about this, and this is readily available via GPs. So this is a newer test that's become available, which we call non-invasive prenatal testing. So non-invasive, obviously not like some of the previous tests. Now, this is where essentially it's we know that fragments of baby's DNA cross the placenta into the maternal bloodstream. So what this test is, it actually involves a maternal blood test, so of the mother, and it's measuring baby's DNA in the maternal blood. And what this test does is and it's important, this is a screening test, so this is not a diagnostic test, and it screens for some of the common chromosome abnormalities. So these are conditions like Down syndrome, Turner syndrome, trisomy 13, trisomy 18. It is not yet available to test for gene disorders like tuberous sclerosis. However, there is a lot of work going towards trying to do this for single gene disorders. There are some complex technical issues, but it's really important that this is not a diagnostic test. This is a screening test. So when someone comes back with a positive test on NIPT, they do need to go off and see an obstetric team to talk about a confirmatory diagnostic test, which is usually an invasive test. So I've just put this in there because a lot of our patients who come to our services for other genetic disorders say, will this condition be picked up on this NIPT test? And some people are being falsely reassured by their general practitioners that this will test for that, and that just goes down to the limitations and the knowledge of these individuals. So I think it's important as families and patients to be aware of limitations of these tests. All right, so I think I'll end there. I apologize for all the technical issues. So, a lot of these aspects that we've talked about are on, obviously, the patient support group website, and obviously the webinar is going to be up there. But this is a sort of an overview on the kinds of discussions that I would have with a family with tuberous sclerosis. Hopefully that's been helpful to everyone else. So I think we can open it up to questions if there are any. I think that's Claire's cue to come back in, I think. Yeah, I can sort of see them on the side. Yeah, yeah. Yeah, I think I mean the two things that we tend to see are so that they're sort of little fibromas. They're a little bit, they're like the growths that you get on the skin. Again, these are benign growths, but you can see them within the sort of oral cavity, and then you can see anomalies of the actual tooth enamel. So we don't know why we get enamel issues in these conditions, but I guess these are the kind of things that will be picked up anyway when your dentist sees you. So it's not necessarily screening because these issues are necessarily more common, but hopefully your dentist will be looking out for them anyway.
Looks like the camera's been switched back on too, so it makes sure I'm awake. Thank you very much, Chirag. We had got a few people typing questions, which is fantastic. We had a question from Carla. We had a question from Carla earlier today asking for more information about the dental aspects of tuberous sclerosis. You mentioned those when you were talking about the surveillance criteria. Did you have any more information to share on that?
Yeah. I think that's the important thing. That again, look, these are guidelines, but we have to factor in the individual person's situation. And in children who do have complex developmental issues, getting to look into their mouth, let alone going to examine them, can be quite difficult. So we have to be quite sensitive to that situation. And I guess families do find their ways of coercing their kids to get to the dentist, or dentists hopefully are getting better at seeing children with developmental issues and how they can actually then do regular dental checkups. But you might have to be opportunistic and wait for an MRI scan where you've got to have a general anaesthetic and get the dental team at that time. That's why you need that coordination of services.
I know a lot of families
and people talking to each other, and sometimes that has to be driven by families because sometimes specialists don't all talk to each other. So I always encourage families to really take that leadership when they're not getting that in their regional centres.
We're looking to, on top of the guidelines, recommend that these things are done in combination with other screening, so that some of those issues, if a general anaesthetic is required, can be combined with MRI scans and those sorts of things.
Oh, I can see there's a question. Yeah. Yeah. So the question is that when you don't have a family history, clarifying that 2% risk. So that is that 2% risk for the, so if we've got, let's say we've got a child who's got tuberous sclerosis, the parents have no clear clinical features, so we're saying essentially there's no family history. The risk of them having another child with tuberous sclerosis is 2%. So that's that situation. But what we're commonly now seeing in the genetic services is families where, as an adult, someone's presenting saying, well, my brother or sister has got tuberous sclerosis, they were diagnosed when they were young children, we've got no family history, I'm a young adult, I'm thinking about starting a family, what's my risk of having a child? So again, the same scenario applies. As an adult person, if you've got an adult sibling with tuberous sclerosis, but your parents are fine, have no clinical features, then you yourself have that 2% risk, and only if you have it have you got that 50% risk. So your child's risk is half of that, which is 1%. So that 2% is for the sibling of someone with tuberous sclerosis when there's no family history.
Explaining that.
Hopefully that clarifies it. No, and I think yeah, just to add to that point is like you said, I think it's asking that question every time and seeing when is it relevant. So sometimes if the family is complete and it's a young child, there's no clinical indications. We talked about why you would or wouldn't do it, but then I guess as that child grows up, and then when they may think about having children, they present to genetic services because they're thinking about all those reproductive avenues. So or because they didn't have it when they were younger, you don't assume that you won't then be offered it later again. So if you say no now doesn't mean no ever. You just have to keep asking, is this the right time for me? Do I want to know? Is it the opportune time for me? And the same with clinicians as well. You just have to be a little bit more persuasive that this is the avenue you want, and sort of direct
clarifying their risk before they went and had children. So the challenging part here is that there are just so many iterations, and I guess these decisions around genetic testing are quite personal and value-driven as well. So,
now that's interesting.
It's not a simple answer.
Now, I'm not sure what the guidelines are. However, I would probably think it's probably not a good idea if you've got tuberous sclerosis to be.
Sorry, Chirag.
Well, it depends which organ. So if we're talking about a kidney, I would probably say no, probably not a good idea. I guess it also depends on your age. Because we know that these features are a lifetime risk. Particularly if we focus in on the kidneys, we're talking about kidney cysts, we're talking about the renal AMLs. We can't predict when those features are going to develop. I don't know if we've got the data yet to say, well, if you get to the age of 40 and you have no kidney features, you're never going to develop any. And I think until we've got that evidence, we would say that person has that lifetime risk of developing kidney manifestations. So would you really, as a person with tuberous sclerosis with that risk, want to be taking out a kidney when you may need it yourself in the future? But also the fact that that kidney that you then donate, if it's going to develop features, you've then given it to someone who really wanted to give them a healthy kidney. So I think at the moment, I probably think they're you wouldn't be top on the list. If you're looking at a family who are looking to donate kidneys within a family, you would probably be lower down on the list than maybe some of your other relatives for all these reasons, not only for your own health. You know, the laws say that as a donor, we have to not do any harm to you, and by taking out, let's say, a kidney that you may need, I guess we would be doing harm to you, regardless of the benefits that would happen for a brother or a niece, etc. And this issue actually comes up with a lot of genetic kidney diseases. So I do an inherited kidney disease clinic for the state, and so this question comes up for these inherited kidney diseases, and so it doesn't matter if it's TS or another condition, the same principle applies. If you've got that risk, we're actually doing more harm by taking your kidney out. Not only that, but also potentially that person you're giving the kidney to would develop that condition. So hopefully that answers Alison's question. Oh,
It's a challenging one. It's a good opportunity to mention. Yeah, it's a good opportunity to mention as well that the reverse is, I suppose, the opposite answer. That there's more and more clinicians pushing that message that just because you have tuberous sclerosis does not mean you're not a candidate for receiving a donated organ. So often lungs and kidneys, and I think sometimes there's a bit of a prejudice that, well, you've got this chronic illness, so maybe you're not the best recipient. And I think that if there's ever a reason for that, whether it's altruistic or a public organ donation, there's strong evidence that if we can keep the surveillance and appropriate interventions right throughout the lifetime, that lots of people with TSC can have a really long, healthy life, and that organ transplant is an option as well. I know it's the opposite of what Alison asked. It sounds like you've answered her question, which is great. Helen's asked a question about, and this I suppose might be a question for your judgment as much as a clear recommendation, but for an individual with TSC as they're growing up, what age do you think that person should start talking to a genetic counsellor, from their own point of view, rather than necessarily their family? Oh, and it looks like we've lost Chirag again. Are you there? I'm just going to type the message to him. This is why Queensland needs to spend more money on their health system, so we have better internet. We're back! Are you there?
I'm back.
Thank you. So we're talking about Helen's question about what age individuals should see a genetic counsellor.
Okay, so I guess it's very driven by families. So the kinds of times we get referrals are for young families where they've had a child with this and they're planning their next child, or they've already completed their family, they've got a new diagnosis of tuberous sclerosis, they want to clarify what the risks are for their other children. And then we've got the cohort who are as adults, I've talked about, either as an adult person who's got a brother or sister with tuberous sclerosis and you're planning a family, or people who have tuberous sclerosis as adults and are planning a family. So it's really when that individual person or family has a question that's relating to all these issues we've talked about today, that is the time to come and see a genetics team. I don't think we can say definitely go and see them at this stage, because sometimes it's not appropriate. Ideally I'd like to think that when you get the diagnosis, that's a good time to go off and see genetics, but there is so much going on for that person and that family, especially with young children. You've got 10 different specialty appointments. You're very focused on managing epilepsy, developmental issues, all sorts of stuff that you don't want to hear about the genetics of it right now. And I sometimes think it's not very appropriate to be sent to us at that time. I also find that sometimes in the clinics where you see 10 different specialists, all of the stuff we've talked about today takes a lot of time, and I don't think we can do that in 5 minutes in one of these specialist clinics. So I think we need families to have the want to come and see us and have that time to maybe to sit down and appreciate all these issues. So I always think it's very family driven rather than specialty driven. I think specialists need to be aware that these families should be coming to genetics at some point, but they should be just facilitating that when the families want to come. I find the biggest hurdle is actually families being aware that these services exist, and then the next step being that their specialists don't know where to send them, which it's not too hard in the days of Google to be able to find where your genetics center is, and sometimes patients call us directly and help facilitate a referral accordingly. So I don't think there's a right or wrong time. I just think at some point it's probably beneficial depending on the question.
Great. It looks like we don't have many more questions, so I'm conscious that it's 4:15, at least it is in the eastern states, and I think looking at the names here, I think we're mostly the eastern states plus dinner time in New Zealand. So thank you very much, everyone, for joining us this afternoon, and for those of you that are now listening to this as a recording, I hope you got a lot out of it as well, and feel free to send us an email with your thoughts. I think for those people that are on the webinar now, they're back and able to put up the evaluation questions so that we can get people's feedback. I don't know if you're already seeing those. I can't see them. But it would be great to have your input. Thank you very much. The more you can tell us in these surveys, particularly in the comments boxes, really helps us explain to people, all our supporters, as well as our fantastic volunteer presenters like Dr. Patel, why these are so important, and what has it meant for you to listen to this information and have this opportunity. Lastly, I have a slide, but I'll leave the survey up instead. I just wanted to tell you a little bit about TSA's upcoming activities. So our next major educational event is our Melbourne Information Day, which is being held on the 8th of October. And I'm pleased to announce in this webinar that we've been able to obtain funding from the federal government to help with the travel and accommodation expenses for people with tuberous sclerosis and potentially with a support person to travel to that meeting. So when I get to my desk on Monday, I am going to take this afternoon and tomorrow off, but when I get to my desk on Monday, I'll be publishing some information about that. So if you're interested to come along to a day where we talk a bit more in depth about all these different complicated aspects of tuberous sclerosis, and you have TSC yourself, we can now help with the funding of your travel to that as well. So it's a great day. We're sort of expecting about 50 people to come together at the Royal Children's Hospital and cover issues relevant to people of all ages with tuberous sclerosis. So if that's something you're thinking about doing, it'd be really great for you to consider that. You can just go to our website anytime from Monday the 14th to hear some more information, read some more information about that meeting and those travel grants. At any time, I'm really happy to receive an email from you, just giving me your thoughts about what TSA should be doing and could be doing to help you. So I think I'll finish off now with a big thank you to Dr. Chirag Patel from Genetic Health Queensland for giving us his time this afternoon. If it was a face-to-face meeting, we would usually present you with a bottle of wine. So feel free to go and raid your own collection of wine and ease into your weekend. Thank you so much for doing this above and beyond your normal job with people with various patients around Queensland. So thank you very much, Chirag.
Okay, thank you.
All right, I'll leave that survey up.
It's a pleasure doing it.
Oh, thank you. And I'll leave that survey up, I think, for a little bit longer. I don't know if Red, that can help us to close down the webinar and leave the survey up. And I look forward to helping you guys into the future. Let me know what it is that we can do to help you. Thank you.